Hello students, I am Dr. Manovijay, Associate Professor from Department of Periodontology, Vinayam Sankaracharya Dental College. Today's topic is about host modulation. So these are the contents of my presentation. So first we'll move on to the introduction. So what is a host? Host can be defined as the organism from which a parasite obtains its nourishment, or in the transplantation of tissue, the individual who receives the graft. And modulation, as we know by the Taber's Medical Dictionary, it is defined as the alteration of function or status of something in response to a stimulus or an altered chemical or physical environment. So what is this host modulation treatment? It is the means of treating the host site of the host bacterial interaction. We all know periodontal disease is a polymicrobial, multifactorial and a complex disease. Development of treatment strategies relies heavily on the clinical research. This is a model of pathogenesis of periodontal disease as quoted by Kornman. We all know in response to the microbial challenge, there is a host immunoinflammatory response that leads to the excess production of cytokines, prostaglandins and matrix metalloproteinases that leads to connective tissue and bone metabolism, which leads to the clinical signs of disease initiation and progression. It is also influenced by the environmental and acquired risk factors, also by the genetic risk factors. So there is a persistent bacterial burden and pro-inflammatory destructive events in the tissues, and it is resolved by the inflammation and downregulation of destructive processes. If there is more amount of resolution of inflammation and downregulation of destructive processes, the health will be restored. Whereas in disease, there will be more amount of pro-inflammatory destructive activities like production of IL-1, IL-6, PGE2, TNF alpha and MMPs. And it also is being influenced by the poor compliance and poor plaque control by the patients. Whereas in health, there will be a reduction of risk factors and expression of host-derived anti-inflammatory or protective mediators. For our example, IL-4, IL-10, IL-1R and it is TIMPs. And it is also been enhanced by the oral hygiene instructions, SRP, surgery, antiseptics, antibiotics, which will all reduce the bacterial challenge. So what are the complementary treatment strategies in perio? So first, in order to reduce the bacterial burden, we have SRP, topical antimicrobial, surgical pocket reduction. And the risk factor modification is by smoking cessation therapy, diabetes control and host response modulation by use of sub-antimicrobial dose of doxycycline for inhibition of MMPs. All will lead to a best chance for clinical improvement. So in this topic, we will be lead regarding the host response modulation. So these are the rationales for host modulation therapy. We should reduce the excessive levels of enzymes, cytokines and prostanoids and should not reduce levels below constitutive levels. Also, we should modulate the osteoclast and osteoblast function but should not impact normal tissue turnover. The key to addressing many of the risk factors that have adverse effects on the host response were either not easily managed like smoking, diabetes or cannot be changed can easily be influenced by host modulation therapy. It may also increase the level of a person's own protective or anti-inflammatory mediators. Overall, HMTs or host modulation therapy should not switch off normal defense mechanism or inflammation. This is very, very important, students, because the main use of HMT is not to switch the normal defense mechanism. Instead, they ameliorate excessive or pathologically elevated inflammatory process to enhance the opportunities for wound healing and periodontal stability. So these are the specific aspects that have been investigated in the usage of host modulatory therapy. Regulation of immune and inflammatory responses, regulation of excessive production of MMPs, regulation of excessive production of arachidonic acid metabolites and regulation of bone metabolism. So here are the potential targets of host modulatory therapy. Here the bacterial products are being dealt with antimicrobials, and the host cells, they produce the excessive amount of prostaglandin cytokine, that is pro-inflammatory cytokines and MMPs, that is being reacted by the post-periostat and also being modified by the NSAIDs, and bone resorption and connective tissue breakdown is being managed by bisphonates, and all this will lead to the reduction in the pockets and clinical attachment loss. So the bacterial component is being dealt by the antimicrobials and host response component has been dealt by the periostat or NSAIDs, and the bone resorption or connective tissue breakdown has been dealt by bisphosphonates, periostat So let us see in depth of each and every one of it. So the key host modulating agents are, first we'll see about the non-steroidal anti-inflammatory drugs. In early 1970s, Paul Goldhaber and Mac Goodson began to implicate arachidonic acid metabolites as important mediators of inflammation, and they have also been reported to cause bone loss in periodontitis. AA can be metabolized via the cyclooxygenase or lipooxygenase pathways. There are two isoforms, that is, as I told previously, it is the COX-1 or COX-2, and COX-1 is expressed constitutively and is known as the housekeeping enzyme. The functions include gastric cytoprotection, vascular homeostasis, platelet aggregation and kidney function. COX-2, it is usually undetectable in most tissues. Its expression is inducible. The word inducible is very, very important here, because it can be induced during the stages of inflammation, and we know periodontitis is an inflammation of the supporting structures of the tooth, and it is upregulated by pro-inflammatory cytokines and endotoxins produced by the bacterium. The COX-2 inhibitors, they have potencies for COX-2 and 10 to 1000 times fold higher than for COX-1. They have lesser side effects related to GIT, liver, platelet and kidneys. These are some of the examples for COX-2 inhibitors: meloxicam, nimesulide, celecoxib, rofecoxib, valdecoxib. Preliminary studies identified that selective COX-2 inhibitors slowed alveolar bone loss in animal models and modified prostaglandin production in human periodontal tissues. But the drawbacks of COX-2 inhibitors include long-term use has been linked to development of hypertension, edema and congestive cardiac failure. Several of these drugs are withdrawn from the market due to life-threatening adverse effects. And next, coming to prostaglandin E2, we all know PGE2 has been extensively studied in periodontal disease because it upregulates bone resorption. Levels of PGE2 have been shown to be elevated in patients with periodontal disease compared with healthy patients. PGE2 also inhibits fibroblast function and has inhibitory and modulatory effects on the immune response. NSAIDs inhibit prostaglandins and therefore reduce tissue inflammation. We know that bacteria produces the LPS. So to manage it, we have the neutrophils, macrophages, fibroblasts, gingival epithelial cells that have an innate protective mechanism in our body. And these also induce the production of prostaglandins, including PGE2. These are potent pro-inflammatory mediators leading to periodontal disease progression, and this has been inhibited by the or blocked by the NSAIDs. Indomethacin and naproxen administered daily for up to 3 years significantly slowed the rate of alveolar bone loss compared with placebo. The disadvantages of NSAIDs include GIT upset, gastrointestinal hemorrhage, renal impairment, hepatic impairment, and the most important thing is rebound effect. So NSAIDs have rebound effect. That means the symptom that persisted previously will again start to relapse once we discontinue the drug. That is called the rebound effect. So this is very, very important about NSAIDs. Today, no topically or systemically administered NSAIDs have been approved by FDA and HMT for the management of periodontitis. So though we have many advantages of NSAIDs, because of its disadvantages like rebound effect, it is not been approved by FDA. This is an important point when you take into consideration about NSAIDs in HMT. Then we have the matrix metalloproteinase inhibitors. So what are these matrix metalloproteinases? These are zinc dependent enzymes, and their sources are from neutrophils, macrophages, keratinocytes, fibroblasts, osteoclasts and endothelial cells. They are capable of degrading a wide variety of extracellular matrix proteins including collagens. MMPs produced by both resident and infiltrating cells of the periodontium play a role in both physiological and pathological events. So these are the classification of matrix metalloproteinase, and we have various groups like collagenases, gelatinases, stromiolysins, matrilysins, membrane type MMPs and others. Of this, MMP8, MMP19 and MMP13 have a distinctive role in periodontitis. MMP8, it has its main source from PMNS, and it has been described to be the dominant collagenase present in the GCF of periodontitis patients. MMP9 is also been produced from the PMNS, that is polymorphoneutrophils, and it is described as gelatinase B. It is also dominant in GCF of periodontitis patients. MMP13, it is being produced from the bone and epithelial cells. It is dominant MMP in gingival tissues and it mediates pathological bone loss. So these three MMPs are very vital in periodontal dissection. And to counteract this, we have the endogenous inhibitors, that is tissue inhibitor of matrix metalloproteinases and alpha 2 macroglobulin. So when there is an imbalance between these endogenous inhibitors and their host derived endogenous and MMPs, it leads to breakdown of extracellular matrix, that is it leads to disease state. Again I repeat, TIMS and alpha 2 macroglobulin are endogenous inhibitors. They are present in normal level to counteract the destructive action of MMPs. So when these MMPs are activated, it leads to the breakdown of extracellular matrix and the level of TIMS and alpha 2 macroglobulin will decrease in disease state. But in healthy state, TIMS and alpha 2 macroglobulin will be in a higher level than the MMPs. This is an important point you should note when you are talking about MMPs. So we have certain components that act as MMP inhibitors, and what are those functions is that they inhibit the synthesis and or release of these MMP enzymes. They block the activation of the precursor or the latent form of these MMPs. So the pro-MMPs, when they are being inhibited, they will not be activated to the active form, which leads to destruction of the extracellular matrix. We are inhibiting the latent form itself, and they will also inhibit the activity of mature MMPs. They will also stimulate the synthesis of endogenous tissue inhibitors like TIMS and alpha globulin for MMPs, or they will protect the host endogenous inhibitors from proteolytic inactivation. So this is an important point when we talk about MMP inhibitors. So one component is the tetracycline. Among that, doxycycline is much more effective in reducing MMPs than any other drug of tetracycline groups in periodontitis patients. Doxycycline tends to be highly concentrated in GCF at levels 5 to 10 times greater than serum and show substantivity as they bind to the tooth structure and are slowly released as still active agents. The reduced dose of doxycycline has been referred to as sub-antimicrobial dose of doxycycline, or in simply as SDD, and it was previously known as LDD, that is low dose doxycycline. In market, it is available as 20 mg dose of doxycycline, that is Periostat. Only FDA approved host response modulating agent is or drug is doxycycline, that is Periostat. It is indicated as an adjuvant to SRP in the treatment of chronic periodontitis. Students, please note, it is not used as the main therapeutic agent for periodontitis. It is used as an adjuvant to SRP in the treatment of periodontitis patient. And here you can see the Periostat tablet. It is available in 20 mg form. So they are useful for reducing pathologically elevated MMP levels without interfering with normal connective tissue turnover. You can see here the action of Periostat at three levels, that is at the epithelial level, connective tissue and bone level. So when you see at the connective tissue level, it will directly inhibit the activation of MMPs by cation chelation, that is the dependent on Ca2 plus and zinc dependent binding properties. Inhibition of oxidative activation of latent MMPs and downregulates the expression of key inflammatory cytokines, that is IL-1, IL-6 and TNF-alpha as well as PGE2. We know these are the host-derived mediators of inflammation. It also scavenges and inhibits production of reactive oxygen species produced by PMNS. Inhibition of MMPs and ROS protects alpha-1 proteinase inhibitor, thereby indirectly reducing the tissue proteinase activity. It also stimulates the fibroblast collagen production. So this is at the connective tissue level. So first and foremost, it starts with the epithelial level. Here it inhibits the production of epithelial derived MMPs by inhibiting cellular expression and synthesis. Now coming to the alveolar bone, the action of Periostat includes, it reduces the osteoclastic activity and bone resorption, it blocks the osteoclast MMPs and stimulates the osteoblastic activity and bone formation, that is it promotes bone formation and it depromotes the bone resorption activity by the MMPs. So the aim of using SDD as a host modulation agent is that to modulate the pathological levels of MMP associated with periodontitis, and it will not inhibit MMP activity completely, as MMPs play a vital role in various physiological as well as pathological processes. This is an important point you should know. It can be used as an adjunct to conventional non-surgical treatment to enhance the resolution of inflammation achieved by the conventional therapy. For most patients, a single course of sub-antimicrobial dose doxycycline lasting 3 months with treatment commencing at the starting of the non-surgical therapy, or it can be used for 12 weeks as an adjunct to non-surgical therapy. When we use Periostat, we have seen significant improvement in PPT reduction, especially in deeper periodontal pockets, and there is a greater clinical attachment level gain. When we talk about high risk patients that are smokers, the treatment responses include, when we use SDD in non-smokers, we get a best treatment response. When smokers, when treated with placebo, they had poorest treatment response, whereas smokers plus STD and non-smokers plus placebo, there was an intermediate response. So, the results of the study suggest that even patients traditionally considered resistant to periodontal treatment, that is smokers, can benefit from SDD with a treatment response similar to that expected when treating a non-smoker by SRP alone. Please note, the candidates patients for using Periostatus, patients' motivation towards periodontal care, that is the patient compliance should be good and they should regularly take up the medicine and they should follow the oral hygiene protocol as suggested by the dentist, and they should have a medical history that is not having too many of systemic diseases, and patient willingness to take a systemic drug therapy should only be the candidate patients, and it is contraindicated in patients with history of allergy or hypersensitivity to tetracyclines. Pregnant and lactating women, you have to avoid tetracyclines or doxycycline derivatives, and children below 12 years because there is a discoloration of dentition, and females on contraceptives. So, again I reiterate, SDD is contraindicated in patients with allergic or hypersensitive to tetracycline group of drugs, pregnant and lactating women, children below 12 years and females on oral contraceptives. So, is there any microbial resistance by using STDs? There have been several in vivo human studies which indicated that long term, that is around 9 to 18 months administration of SDD does not result in emergence of resistant organisms or alteration of the subgingival microflora. Whether continuous administration or multiple applications to the same individual over longer time intervals results in microbial resistance or the emergence of resistant strains has not been determined. So, it can be safely used because still now there is no microbial resistance to this low dose of this SDD, and you can be administered or multiple application to the same individual. Next, we have a special group called chemically modified tetracyclines. It is achieved by removal of the dimethyl amino group of the A ring of the 4-ring tetracycline molecule. That is why it is called as a chemically modified tetracycline. It is devoid of antimicrobial bacteria. Then what is it used? It does not have an antimicrobial activity, but it retains its anticollagenase activity. Very important here we have to note is that it has an anticollagenase activity. The anticollagenase activity of chemically modified tetracycline is specific against the collagenase produced from neutrophils but not from the fibroblast. It does not affect the normal collagen turnover required to maintain the tissue integrity. So, the normal collagen turnover is not being affected. So, we have got chemically modified tetracycline from 1 to 10. Among that, CMT8 is the most potent inhibitor of periodontal breakdown. CMT8 along with 1, 3, 4, 7 and doxycycline inhibited TNF alpha, IL1, IL6 and MAPs in descending order. That is CMT8 is more potent than 1, 3, 4, 7 and doxycycline inhibited TNF alpha. The potency of CMT8 is higher than that of its variants. CMT1 and 3 also inhibit gingipines, that is the virulence factor produced by P. gingivalis. Now, we have got a peculiar molecule or a new molecule called pesbins that has also been tried in host microbial therapy. It is nothing but polyenolic zinc binding proteins. They are the new MMP inhibitors from natural curcumin, and chemically modified curcumin show potential host modulatory activity. One more is that SAGE, that is a novel semisynthetic glycosaminoglycan ether. It is used to suppress inflammatory mediators in high risk individuals such as smokers and those with diabetes based on the ability to reduce the impact of advanced glycation end products, reducing the pro-inflammatory mediators of disease. Next, we come to the another group of drug called bisphosphonates. They are analogues of pyrophosphate in which the oxygen is replaced by carbon with various side chains. These are class of drugs which disrupt the osteoclastic activity and inhibit the bone resorption. Their phosphate carbon phosphate structure permits them to bind to calcium, and the bisphosphonates are able to bind to bone surfaces, thereby protecting against bone resorption. There are severe unwanted effects of bisphosphonate therapy. Some bisphosphonates have the unwanted effects of inhibiting bone calcification and inducing changes in white blood cell counts. Bisphosphonate related osteonecrosis of the jaw. It is characterized by exposure of necrotic bone in the mandible or maxilla and risk of infection, particularly following dental procedures such as extraction. That is, persons or patients who are undergoing bisphosphonate therapy will have osteonecrosis. As the bisphosphonates are potent osteoclast inhibitors, their long-term use may suppress bone turnover and compromise healing of even physiological micro-injuries within the bone. So, use of bisphosphonates as an adjuvant treatment for periodontal disease is not indicated. Again, I repeat, the use of bisphosphonates as an adjuvant treatment for periodontal disease is not indicated, and NSAIDs is also be not indicated. As of now, only Periostat is the only FDP approved drug for host modulation therapy in periodontitis. So, moving on to the next topic, we have got the anti-cytokine therapies. In periodontitis, we know the pro-inflammatory cytokines and TNF alpha and also PGE2 MMPs are produced from fibroblast monocytes and other cells. They lead to the connective tissue catabolism and bone resorption. So, if we block this, can we improve the periodontal health? That was what has been tried with the anti-cytokine therapies. These cytokines are present in periodontal tissues and their levels are elevated in disease state. That is, the pro-inflammatory cytokines PGE2, TNF alpha are present in the periodontal tissues in a normal subclinical form, but their levels are increased in disease state. There are endogenous inhibitors of IL-1, TNF alpha to counterbalance their catabolic activity and maintain homeostasis. That is what we saw previously as TIMS and alpha macroglobin. The anti-cytokine therapy is via neutralization of cytokine receptor blockade and activation of these anti-inflammatory pathways. So, these are the biological therapies that has been tried now. Currently, anti-cytokine therapy using anti-IL-1 or anti-TNF alpha monoclonal antibodies and soluble TNF receptors have been approved for the treatment of rheumatoid arthritis, Crohn's disease, juvenile arthritis and psoriatic arthritis, with research continuing on the periodontal disease. Some of them include infliximab, adalimumab, etanercept and anakinra. So, this monoclonal antibodies to TNF alpha, soluble form of TNF receptor and receptor inhibitor for IL-1 RA. The disadvantage include the harsh enzymatic environment in periodontal lesions may destroy the soluble cytokine antagonists prior to their peak activity, which may necessitate more frequent administration of the active agents to the defects, and they function as a network and share overlapping features, which is termed biological or functional dependency. Hence, blocking one cytokine will not assure that receptor mediated response will be activated by alternate pathway. Next, we come to the nitric oxide synthase inhibitors. Nitric oxide is a short-lived molecule implicated in a wide range of biological processes. NO is produced at high and prolonged concentration in response to pro-inflammatory stimuli such as lipopolysaccharides via inducible nitric oxide synthesis. Although nitric oxide has an antimicrobial protective activity, it is elevated concentration in the tissues has a cytotoxic effects to the host cells too. A reduction of alveolar bone loss and gingival inflammation after the use of a selective INOS inhibitor, mercaptoethylene guanide, confirming that nitric oxide has a deleterious role in the pathophysiology of periodontitis and that its modulation may prevent tissue destruction. So, now we have the inversion of the treatment paradigm, that is, we resolve the inflammation and you will control the infection. This is the recent concept. What is this resolution of inflammation? It is an active process involving biochemical circuits that actively biosynthesize local mediators within the resolution phase. Effective resolution including effective removal of leukocytes and return of the resident cells to a no inflammatory state, and it has been referred as catabiasis. Lipoxins and resolvins are specialized pro-resolving mediators that play a crucial role in resolving inflammation, including periodontal disease. They actively promote the resolution of inflammation by reducing neutrophil infiltration, facilitating the removal of apoptotic neutrophils and enhancing tissue regeneration. In periodontitis, these mediators can help to dampen the damaging effects of inflammation and promote healing. The key roles of lipoxin and resolvents in periodontal disease include: they promote resolution, that is, they actively resolve inflammation by reducing neutrophil recruitment, which is very important in an inflammatory stage, and they promote the removal of apoptotic neutrophils and enhancing the clearance of inflammation. Next one is, they promote periodontal ligament regeneration. How it is being done? It is by resolving D1. It has been shown to enhance wound healing and proliferation of PDL cells, which are crucial for maintaining the structural integrity of the periodontium. Receptor expression, that is, resolvents expert their pro-resolving action through specific receptors and cells, including PDL cells, and their expression on these cells is an area of ongoing research. They also been used as potential therapeutic targets. The ability of resolvents to promote resolution and tissue regeneration makes them promising therapeutic targets for the prevention and treatment of periodontal disease. Nutraceuticals or omega-3 fatty acids like EPA and DHA, which are precursors of resolvents, can be incorporated into diet to potentially enhance the body's natural resolution pathways. We have aspirin-triggered lipoxins. Aspirin can modify the production of lipoxin and resolvents, leading to the generation of aspirin-triggered forms that may have longer lasting and more potent effects. So, apart from the regular HMTs what we saw, we have other HMTs in the market like probiotics, endogains, infused bone graft and GEM21S. So, the summary of my presentation is that these are the very important key points the students you should always remember. HMTs are an emerging treatment concept in the management of periodontitis. The use of HMT as an adjuvant may be particularly useful in susceptible, high-risk patients in whom a prolonged and excessive host response to the presence of bacteria promotes the activity of MMPs and osteoclasts. SDD is the only systemically administered HMT currently approved and indicated as an adjunct to SRP for treating periodontitis. In the era of periodontal medicine, systemic host modulation approaches need to be considered. Host modulators used to manage periodontal disease may have additional beneficial effects on systemic diseases that have been linked to periodontal disease, such as cardiovascular diseases and diabetes. Also, patients who are currently taking host modulatory agents such as NSAIDs, bisphosphonates or tetracycline for other medical conditions may be experiencing periodontal benefits from these systemic medications prescribed for the management of other inflammatory conditions. So, the conclusion is that the challenge remains to harness the knowledge created from basic science and animal studies to develop and evaluate these molecules as new drugs and to evaluate the risks and benefits associated with their clinical use, as well as their unwanted effects, interactions and the variations in response profiles between individuals. So, these are my references. Thank you, students.